Hi, welcome to this EAUTV. Today I will discuss BPH, BPO and male LUTS with Marcus Drake from UK and Thomas Herrmann from Switzerland. So we have seen during the Congress especially a lot of new information relating to male LUTS in general, and it has popped up that the prostate is not always in question in male LUTS. Can you discuss about this, guys?
Yes, I think it's it is not new, but it's now popping up, as you say, and this is, I always call it like patient expectation management. So the patient comes to you and says, please make me get rid of all symptoms, bothersome symptoms that I have. And the distinguishing between storage and voiding symptoms, for example, is sometimes not clear, not only to our patients, but sometimes also to our referral doctors. And I think especially irritative symptoms or storage symptoms have become a focus of concern. We know that most of our patients approach us when their nocturia episodes cross the 2 to 3 border. And then there's always a question, can you get that away by performing surgery or not? And the truth is, you can only be successful in a certain percentage of that people and not in all, because there's let's say, plethora of reasons behind nocturia, just as one prominent bothersome symptoms for the patient, that needs to be assessed before engaging into surgery or treatment. Yeah?
The issues may be even more general, Marcus.
Absolutely. I think the EAU has been very strong because it's recognized that, to use the term BPH, a clinician seeing a patient saying to their patient, you have BPH, then the patient starts to expect prostate treatment. And this automatically biases the consultation towards a prostate dominance. I think EAU has been so much stronger than, for example, AUA, who sticks with BPH, who uses International Prostate Symptom Score. Their bias towards prostate intervention is almost forced by the terminology. So by saying lower urinary tract symptoms, we can talk about the clarity of there can be a bladder issue, there can be a prostate issue. The bladder issue is going to give you storage problems like urgency. The prostate issue may give you slow stream. And there's an interaction between the organs of the urinary tract in generating these symptoms. And that means, by using this term LUTS, we just recognize the role of the bladder, the role of the prostate, and in nocturia, the role of urine production. And we're much more thoughtful as a result.
Absolutely. I mean, we have in the guidelines, we got even more deeper in these voiding symptoms, saying that even voiding symptoms, but not only storage, can be linked to a bladder dysfunction, Thomas.
Yeah, absolutely. And especially, I think one thing is very important. We are dealing with a different set of population 10 years ago or 20 years ago and now, because in between came the asymptomatic phase of medication that prolonged for a long time also prostatic growth and the overwork of the bladder diffuser, which eventually, this is my interpretation, there's no clear data on that, Marcus can tell much better about that, but I have the feeling that I'm seeing much more deteriorated bladder function today in patients that present for prostatic surgery. Of course, I'm dealing with a lot of big prostates, so for enucleation, so long patient history with their disease. I see a lot of deteriorated bladder with detrusor underactivity, even detrusor acontractility, that makes it very complicated to solve. It's not solvable alone with surgery. You need to get the urotherapist into it afterwards and see if bladder training or assisted voiding trained by urotherapists can solve that problem. Yeah.
It's a horribly challenging situation. So maybe working hard against a degree of prostate obstruction causes the bladder structure to deteriorate, but it's certainly not proven. Simply aging
Yeah.
Simply diabetes, simple obesity, all are associated with deterioration in bladder function, for example, in women. So the men must have the same pathology. So it's certainly not proven that working harder causes that particular problem. Perhaps it's protective for the bladder because you get more muscle mass in the bladder by hypertrophy. So I'm certainly not a fan of early obstruction relief surgery to try to prevent bladder problems, because I think then you have a miserable symptomatic condition. The patients tend to be upset because they see little symptom improvement. They see adverse effects. And they thought that 5 years from now, maybe their bladder is better, but that's not proven. Is hard for them to hang on to as a reason for an operation.
Well, absolutely. And about the treatments you were mentioning, we see more and more minimally invasive surgical treatments, so-called mists, coming in the area. Unclear competitors to medical treatment, competitive to surgeries. How do you interpret the growing importance of these options in the field of male LUTS interventional management?
I think it's very nice that we have this variety of options today, because I think we are taking men more serious today than we used to do 20 years ago. So the loss of ejaculation, for example, is something which was not really on our list the last 20, 25 years. And by the arrival of MIST, we are forced to understand more of what we're doing surgically and to take it serious if somebody comes and approaches us with the wish to preserve that. I feel with these MIST that are very elegant solutions in some index patients, that we need to educate our patients better about ejaculation. So in my practice, if the patient understands that antegrade ejaculation is not linked to orgasm, so sexual fulfillment after intercourse, there's a very low percentage who then wants to go for ejaculation sparing, because they are most afraid of loss of erectile function and loss of orgasm. So if this is gone, most of the patients then step back from, I take the possible disadvantages of a less invasive treatment in order to preserve my ejaculation, because they patient-informed consent. So again, take your patients serious, educate them, and then they can make the right decision based on on your, let's say, working box you have to solve the problems.
But we have got to be careful, haven't we? We learned a bad lesson when we introduced mid-urethral tapes for stress incontinence surgery in women. It's proved a disaster. At the time, in the UK at any rate, we were slow to start, but then we took to them very happily because they're easy to do. Unfortunately, it's the 10 to 15 year outcomes that have proved the problem. So is there a similar situation here in male surgery? Well, I hope it's not an equivalent disaster coming along, but we still need to be strongly advocating for the patients that the minimally invasive interventions must prove their merit. And at the moment, you hear a lot of claims made by companies. Very little evidence is actually being produced that you can really trust. Now, in UK, the government has funded a £2 million study to randomise between 4 of the minimally invasive interventions. And we hope that we can deliver that study, and then actually we got evidence of efficacy, patient selection, and adverse events. Our difficulty comes with the surgical community is not very good at participating in research, and actually recruiting to that sort of study is proving difficult.
Absolutely, but I think we need more and more information, more and more reliable science behind this. I must say that the EAU guidelines are one of the most cautious in the world in approving or not, because the rules of the house are quite strict. Yep. We need those RCTs, we know these endpoints that are composite about symptoms, about patient satisfaction, and we need medium to long-term results. Exactly in line with what you say. I feel that the patients are, believe in what we do. So at the other side, we must be absolutely perfect on our rationale when we propose a therapy.
I fully agree with what you said. And what I think is the problem at the moment is that we haven't adjusted our goals in the guide, cannot adjust our goals in the guideline because the evidence is not there, as you say. But if you take that endpoint, antegrade ejaculation, serious and set this as the major concern of the patient, then our traditional efficacy measurements like stream, post-void, residual, urine, and IPSS or AOA symptom score, whatever, as long as there's not data, we cannot change our vantage point other than claiming we have now tools that prevent at a very certain degree that you get retrograde ejaculation. And what is always my words in it, I said it's not the tool. We have to understand the templates we are treating. We have to understand the anatomy that we are treating, because if prevention of retrograde ejaculation is a need, we have to look for a global solution for that. And it cannot be a global solution thinking of funds, of socioeconomic systems, that we advocate that if you want to prevent ejaculatory function, you have to use this or this tool. This is too expensive for most of the societies around us. So this is why my push is always understand the anatomy and understand why these tools work so well with this regard and fail with regard to durability on the other regard. And this is why patient selection, again, is paramount. And we are in the process to understand which is the index patient for durability, I would say. And I think you're on the safe side if you stay within the initial inclusion criteria of these studies and not overexpand it, because I think that's most likely the patients that will fail if you're outside that initial scope of patients.
Yeah, when we talk about ablative options, Marcus, I've seen that some clinical items may be enough relevant to avoid urodynamics before proposing these ablatives, and even avoiding to make some patient worse. What are these clinical symptoms that can guide practitioners to propose their TURP they are confident in?
Yes, so the Upstream study was the UK's government-funded study where we randomized people to a conventional assessment of flow rate, symptom score, bladder diary, urinalysis, physical examination, against urodynamics with those. And we published in European Urology Focus a summary where we were able to pull together the predictive factors that really anticipated good or bad outcome from surgery. Now, the good outcome from surgery always came down to a man who had severe symptoms, and the symptoms were dominated by bother from their voiding symptoms. Okay. So if they had storage symptoms and less bothersome voiding symptoms, they often did very badly. The other predictive factors alongside severity of symptoms, dominance of voiding symptoms, was a moderate flow rate, below 13 mils per second, and not too much comorbidity.
Okay.
Now, if that applied, if they were all those, then there was no need for urodynamics. You could anticipate a good surgical outcome in the big majority. Away from that, any aspect of that was missing, urodynamics could then anticipate how they might get on. And you needed to get a clear demonstration of a bladder outlet obstruction index above 47 and reasonable contractility. If both those apply, surgery often did very well. But if anything was wrong, most people did not improve, in which case they were quite unhappy. And some people got worse, in which case it really is unacceptable. And the important thing to bear in mind is it's not a trivial proportion that got worse. Mm-hmm. It was a significant proportion that got worse. And those people are miserable. So you really should, in every case, get a symptom score, a proper one, a bladder diary. You should do the full EAU panel of observations and have urodynamics in reserve if you've got a non-ideal candidate.
Excellent. So we see times are changing. We have more and more options, but it remains more and more difficult to understand exactly what happens in each patient. So that's probably our mission, to raise the bar for patient care and a better clinical practice.
Yeah.
Thank you very much for this discussion.
Thank
Greatly
you.
appreciate it.
Yeah, no, beautiful.
Thanks. Thank you very much.
Happy.